Chicago, and I appreciate you taking the time to go through some patients and try to improve patient satisfaction and outcomes. I suppose that's what we're doing every day in our clinics. So I'll just run through the program objectives. I think you've seen these before, but we certainly hope that you'll be better informed on therapies and treatment paradigms, thinking about side effects that might reduce adherence, understanding the approach to new paradigms for treatment, including 2-drug regimens. Think about rapid start for a antiretroviral therapy and its advantages and potential disadvantages. Some new information about long-acting drugs, and then other future directions. So this is a fully accredited program through the University of Chicago Pritzker School of Medicine, sponsored by ViralEd, and it's good for 1 AMA PRA credit. I was lucky to work with a really outstanding faculty that included Joe Aron, Ian Frank, and Paul Sachs. And these disclosures of interest are coming. Here you see them. And the usual disclaimer about messaging and program notes. And, you know, these were programs designed to be live. I regret everything about COVID-19, but especially that we can't be interactive together. And I think my hope is that we try to accomplish at least some of that through the use of chats in this virtual forum. So if ideas, questions come up, you're really welcome to put them in the chat or just to unmute yourself and say them verbally. And I don't mind interruptions. It certainly will add to your learning if you're able to answer questions as they arise. So these are the potential case topics. And I think what I'll do is at least plan to go through the first 2, and then maybe we can reconnoiter, or I'll just continue on through them. The first is to talk about the intersection of HIV and COVID, and then starting therapy in the modern era, when and what to start, and the question of rapid start. And then a little bit about what's new with treatment experienced patients in terms of simplification, 2 versus 3, the question of resistance or hepatitis C co-infection with treatment experienced patients. And then the last 2 topics are toxicity related weight gain and other adverse event management after rapid therapy. So, but since COVID-19 is still the 600-pound gorilla in the room, let's take a case and think about the issues involved in HIV and COVID-19. Certainly one major one that we're all worried about is HIV a risk factor for severe COVID-19? I was just involved in a administrative discussion in my section at the University of Chicago on how and when to prioritize our patients next after we finish with health workers, including people with HIV. And the question about HIV medications with activity against SARS-CoV-2, which I see as largely settled, and I'm not going to spend much time on that. As you all know, lopinavir, ritonavir was the subject of early trials in China and around the world, and was disappointing in that regard. So I think the answer so far is no, though we still are searching for effective therapies. And the question of how to counsel people effectively. So we've all seen this list. It's growing. I think it's very important to pay attention to what are comorbidities that render one more susceptible to more severe COVID disease. And it's older age, chronic lung disease, cardiovascular disease, diabetes, obesity, immunocompromised patients, end-stage renal disease, and liver disease. And that immune-compromised category certainly has included all people with HIV, and then among people with HIV, those with more advanced disease, with lower T cells, with uncontrolled viremia, probably would be at the top of the HIV list. But there's still some uncertainty in that. I'm very pleased to say we did a natural history study here in Chicago, and the title is actually the title of the presentation that we made in November in the Glasgow HIV meetings. In our hands, cancer, transplant, HIV, and other immune compromising conditions themselves were not associated with a greater risk of severe COVID or death. And there's a lot of information on this table, but a couple things to see. Now, this was a population that was 90% African American, and about 400 patients in March and April of 2020. And you can see that 40% of people met a definition for severe COVID illness, which meant high flow oxygen or ventilation, intubation, rather than just people requiring room air. And then all-cause mortality was part of that definition. And like every other report, we found that people with hypertension, with diabetes, with chronic kidney disease, with heart failure, were at a greater risk for more advanced disease. Interestingly, in the univariate analysis, obesity was not a predictor, but when we looked more carefully at by multivariable analysis, indeed, both obesity and morbid obesity were associated with greater likelihood of death or severe illness. But it's the items that are highlighted in red that I'll call attention to here. There were 56 cancer patients in this group, either current or past cancer. There was no signal there of a greater risk of more severe disease. And in the other large group, there were 8 people with HIV, a number of people with solid organ or stem cell transplants, patients on chemotherapy or on steroids or other immunosuppressive agents. The total of 55 patients, and again, there was no signal in that group that they were at a greater risk of more severe disease, that they fit with the rest of the population who had a 40% incidence of severe illness. So I don't want to misrepresent this. They are still at risk for serious disease, and a number of people died, but it's not greater than the rest of the population without immune compromise. So in our hands, we saw that age was by far the strongest predictor, and this is true around the world. I'll show you some of that data. Here, in fact, here in Illinois, 45% of people of our deaths were in people over age 80. There was a lesser extent, but still significant finding with diabetes and chronic kidney disease and obesity, and we found no association with cancer, transplant, and the other immunodeficiency syndromes. And the literature suggests that if you're well controlled and you have higher T cells, there may not be a higher risk of severe disease. And I'm going to share some of that with you. But the very important finding in several of the cohorts that those with more advanced disease actually are at greater risk. And then there's certainly more data that's needed on this question of transplant and cancer. So I would just say, since we found these in August, what we've seen is that hematologic malignancies, solid organ transplants, and other cancers within the past year all appear to be associated with a greater risk of severe disease. So just let's look at some of that data. This is from the VA cohort study, which is the largest cohort in the United States. They found 253 of their individuals living with HIV who were also COVID infected, and they compared them to 2 times as many uninfected individuals. And they looked at hospitalization, ICU admission, intubation, and the risk of death. And there was no difference in those who were HIV positive and those who were HIV negative. Now that, to my mind, is the biggest and I think the largest series on that question. Now, on the other hand, many groups have gotten together and pooled their patients. And so this was a group of 286 people, an equal number, from 36 institutions around the US. And in this series, comparing all people with HIV, there was a greater likelihood of mortality or severe disease in patients who had less than 200 CD4 cells. So you do get that sense. And then I think these data are really interesting from South Africa. So this is an international cohort where actually, if you look down here at the bottom, HIV was associated with a 2-fold risk of greater mortality compared to people who didn't have HIV. Now that was the same for people with tuberculosis, and that may mean that there's a lot of overlap between those 2 groups, and that may be as much a TB marker as an HIV marker. But what I like about this particular graphic is it shows you proportionally that age is by far and away the stronger predictor. So a 5-fold or greater risk was conferred just in those patients who were age over 50, 60, or 70 in this series. And the next strongest predictor was diabetes. And I think that reflects very well what the literature is telling us. So these are twin pandemics, and because of the overlapping comorbidities, it's reasonable to think that people with HIV may be at greater risk even at a somewhat younger age than others. And as you all know, there's high rates of COVID-19 among racial and ethnic minorities. And so we have to consider the structural factors that put people in harm's way as essential workers, bus drivers, food service workers, grocery store workers. And that's clearly is playing a role. I would add to that mass incarceration and its impact on people of color and communities of color, meat packing and forced congregate settings of that nature, homelessness and living in shelters as a risk factor. So we think of the narrow medical comorbidities, we probably should expand that to include comorbidities that are a result of structural violence and violations of human rights. So, I think it's very important for HIV clinicians who have been down this road, particularly with stigma reduction and the need to do outreach and engagement in care in populations at risk. I think caregivers for HIV have a lot to offer. Fortunately, there are some excellent resources for this purpose. The IDSA put out a very early set of guidelines in April of 2020, and that's been updated regularly. So we should think a little more about how do we counsel our patients and what are the issues, just so that we can continue to provide good HIV care and PrEP care in the meantime. If an HIV PI is not part of a person's regimen, then there's no reason to change it to include a PI on the basis of COVID-19. As I mentioned, that's old news. Certainly it's important to maintain an adequate supply and, if possible, to get your patients onto 90-day supplies. Make sure that they're updated with flu and pneumococcal vaccines. And one of the byproducts from COVID-19 has been an extraordinarily low incidence of influenza nationwide and worldwide, and that's one of the few benefits of COVID-19. So the DHHS guidelines have also issued their report, and this continues to be updated as well over time, with some very useful sections for COVID in pregnancy and in children, in settings of opioid addiction, and the ongoing need for hand washing, and when to send someone to the ER, how to work with the mental health issues that are associated with this, and just how to conduct e-visits and maintain contact virtually. And I think all of you as HIV caregivers probably know now that our need for contact is greater in the COVID-19 pandemic. And so taking the steps to text or to talk on the phone or do e-visits, I think, is really very rewarding and in our patients' best interest. And again, there you see in the box that the available data in both of these guidelines is by itself in a well-controlled individual on HIV therapy with T cells over 200, there is not a greater risk of more severe disease. There's been several papers about the impact of COVID-19 on PrEP. Unfortunately, STI testing is way down. PrEP refills are way down. Now, some of that may be a rational response to just declining sexual interaction, and that clearly is also a byproduct. But I think we should be responsible and proactive. We can still talk about the recommended HIV quarterly testing and think about other durations for lab-only visits, maybe have lab-only visits and do some of our interactions by phone or by e-visits. There are some groups that are working on home specimen collection, both for HIV and STI kits, and again, looking at long-standing medication access. So, that's a brief overview of COVID-19. I didn't think it was appropriate to go all the way through our therapies, but it's important to mention, I suppose, we do have interventions that matter and people should go to the emergency room. And for those that we diagnosed and sent home, 10% ended up coming back to the ER and being admitted. So we have to inform people, even if they're feeling better, be careful and look out for red flag symptoms for 2 weeks. And they need to understand that with remdesivir, with dexamethasone, we have seen a continuing decline to less than 10% for hospitalized people with COVID-19 at the University of Chicago and in many other centers. So it's in their best interest to be vigilant and to still continue about going home. I guess the last thing is how extraordinarily difficult chronic COVID-19 is proving, with many, many patients, 20% possibly more, having ongoing chronic symptoms like arthralgia and myalgia, exertional dyspnea, mental health issues, and CNS symptoms like confusion and brain fog, so-called brain fog. But that's dominated our lives, and we want to stay focused on HIV in this talk. So I'm going to turn then to just considering treatment-naive individual, when to start, and the issue of rapid therapy and rapid onset of treatment. So let's consider this patient. This is a 22-year-old Latino referred from STD clinic, which also has a clinic in your health facility, which is a very handy way to work if you have an STI clinic next to a primary care or an HIV clinic. So this young man was seen in the clinic in the morning, was diagnosed with urethral gonorrhea. He was called back when his 4th generation HIV test was positive. So this is a new positive in the setting of an STI. He is a man who has sex with men with multiple partners. He's an exclusive top. He's had HIV tests regularly, and he was last negative 3 months ago. So this is clearly an acute infection. He was previously syphilis antibody negative, and we know that he's HPV immune with a history of vaccination. You know, and we've always inquired about hepatitis and hepatitis status, but in this era, it has an additional value and importance because of the question of, are we going to use a 3-drug therapy that includes 2 drugs with activity against hepatitis B, commonly tenofovir or tenofovir alafenamide, plus lamivudine or emtricitabine. And some of the 2-drug regimens lack both of those 2 drugs. So it becomes additionally important in patients where 2-drug regimens may be considered. So this young man experiments with chemsex and uses no drugs chronically. He binge drinks, but he's never taken a regular medication. So you have to wonder about adherence right off the top. He's interested in HIV treatment, but he wants to know how often would he have to come and see you? What kind of a nuisance would this be in his life? He lives with an older sister on her couch, which is one form of relative homelessness. Works at a local restaurant, and he's on his mother's insurance. And he thinks that she would want him to be treated. That's maybe an important and influential issue. So the questions then we think of are, he should definitely be treated. Should he be treated right away? What lab tests are we commonly ordering in a pre-treatment? What therapy would you want to choose? And you can think about these questions as I go through them in your mind. And then, is he candidate for 2-drug therapy? And we give you the prompt here that, remember, this person is known to be hepatitis B surface antibody positive. So would you start him on antiretroviral therapy today? Well, so some of the evidence behind this has to do with the time to virus load suppression. And this is a study out of San Francisco where they implemented a rapid start program. And what they found was very quick achievement of virus load suppression. So 95.8% at 1 year after treatment, and virus load at the last record of 92%. So spectacular outcomes in this population. This is 225 people. It's important to say that this was half of these folks had substance use or a chronic mental health disorder, and a quarter were homeless. So living in rough circumstances. And so the question is, when you're first seeing this young man, should you give him a bag full of medications and say, take these, I'm going to do some laboratory tests, and when you return, we'll talk about, can we continue that same regimen? And so I think there are a few things to say off the top. Let's look a little bit at some of the additional literature on this subject. These are some studies out of South Africa that looked at a variety of different indicators of either treatment within 7 days or less, or treatment on the very same day, or treatment within 14 days. And you can see in each case, compared to the standard arm where they just did the usual thing, which oftentimes would take several weeks, the intervention arms were better. And they were better at each of those different markers, supporting the notion of that there's value in prompt therapy. And I think one of my reactions to same-day therapy is great if you've got the infrastructure, if you can guarantee a supply of medications, if you have savvy providers who understand that limits the number of regimens, and there's some regimens that should not be used in that setting. So I also think same day, if you think of rapid start, that there's value on the very same day, but rapid start can include up to the first week or two, as you see in that definition. And there still are benefits for rapid virus load decline and a quick achievement of full suppression. Now that clearly has a public health benefit as well as a benefit to the individual.
Dr. Sherer, it looks like there's a question quickly.
Yeah, please.
What about screening for HCV in this case?
Great question. Without question, this young man who's at risk, he's already been immunized against hepatitis B. Somebody thought to do that, is at risk because of the sexual transmission of hepatitis C. So he certainly should have included in his early laboratories a hepatitis C antibody test. And let's think just for a minute, let's finish that list. He should have basic metabolic profile and urinalysis. We know that there's circulating resistance mutations in the community that might jeopardize our regimen, so he should have a resistance test. Everyone should have it. Every woman coming to the clinic being ready to start antiretroviral therapy should have a pregnancy test and should have reproductive health counseling. If there's consideration for the use of abacavir, then you would want to do an HLA test. And that actually raises a very important point that we don't recommend, and the guidelines don't recommend the use of abacavir in a rapid start or a same-day start regimen, because you couldn't know in advance whether or not they have the HLA-B resistance mutation, or sorry, mutation that would confer an allergic reaction to abacavir. So we don't recommend abacavir in that setting. There are actually preferred regimens for early start, and they include the integrase inhibitor 3-drug combination of bictegravir with TAF and FTC. They include the 4-drug regimen co-formulated protease inhibitor, and we're going to get to that regimen with boosted darunavir, TAF, and FTC. The remainder of the slide just has a couple of other experiences, and it's very important to say that the literature is not wholly in support of same day. There are some glitches. So in Rwanda, when they did a retrospective cohort study of people initiating therapy, those who started right away actually were more likely to be lost to follow-up. Now, those data might have been confounded, but it does raise the issue of the need for longitudinal follow-up and to establish a connection. Certainly the people in San Francisco and others who do rapid start have said the bond created between provider and patient is a powerful one when you say you have a life-threatening problem and this is the remedy here in this bag, and I'll see you next week. Start taking those right away. But it takes away a little bit of the patient's agency to choose which regimen or side effect profile they might like. And as I mentioned, you could have a conversation and say, come back if you have more than one clinic in a week, come back this week, or come back in 1 week and we can finish that decision-making process and start. In my mind, that's prompt antiretroviral therapy, which was associated in that South African study with an improvement in the likelihood of virus load suppression. So also, I just want to give a shout out to Thailand, and this is through the Thai Red Cross, where they ramped up. They said, this will work in our population, we want to do this. And with a huge scale of 3,800 patients, they did it in 3,000 patients starting on the same day, and they had exceptional retention in care and virus suppression of 96% retention, 94% suppression at 12 months. So the last thing I'd say in relation to US studies on same day is it hasn't always led to a greater likelihood of virus suppression in a population. Some studies it has and others it has not. It also has not necessarily been associated with greater retention in care. In Atlanta, it was the same as in the group that got treated in the usual way. So it isn't always providing, advantages all the way through. Most studies that have looked at it have said it will shorten the time to virus suppression and it will lower the community virus load and lead to an immediate public health benefit. And that is certainly one of its benefits. So this is the DIAMOND study. This is the boosted darunavir co-formulated with cobicistat, FTC, and TAF. And it was designed as a rapid start approach. And they did an analysis both at 24 and 48 weeks. You can see they're very similar with very few failures, 13% at 24 weeks. And those aren't failures, they're just higher than 58% in the other group. You all will immediately recognize that the boosted protease inhibitor approach reduces anxiety about poor adherence. You know, we often say if you suspect or know somebody has a record of poor adherence, a boosted PI is a good option because it takes much longer for them to develop drug resistance. You're less likely to blow one of the classes if you have that approach with that regimen. What's the downside of the use of boosted darunavir? The boosted PIs, first of all, it's a very large pill, so someone has to be able to swallow it. And then boosted PIs have a little more GI toxicity, 5 to 10%, bloating, loose stool, nausea, as compared to the integrase inhibitors. So the integrase inhibitors are by far the best of the tolerated. But you can see, oh, and sorry, these are the Gemini 1 and 2 results. So now this is the clinical trials where a 3-drug regimen of TDF, FTC, and dolutegravir was compared in a drug-naive population to dolutegravir 3-TC, and after 48 weeks, they were identical. This was actually extended out to 2 years and then to 3 years worth of follow-up, and still not only comparability, but actually against some comparators, superiority. And one of the great things about the 2-drug regimen that certainly was a source of uncertainty when they were first developed was the possibility that there would be more breakthrough viremia and more drug resistance in those who did break through. And you can see here now, this are the 96-week follow-ups in the Gemini study. First of all, it was found to be non-inferior. There were only 11 people in the 2-drug arm who had a so-called confirmed virologic withdrawal. And most of those patients actually ended up with a virus load that was just barely above 50, or in one case, quite high, but in a patient who was known to be non-adherent. None of these folks developed drug resistance. And so that's a very reassuring for the value of the 2-drug regimen. It's my own personal practice at the moment to limit the rapid start to the boosted protease inhibitor regimen or to the 3-drug regimen using one of the 2nd-generation integrases. In my opinion, that would be bictegravir plus TAF and FTC, or dolutegravir plus TAF and FTC. So now we're talking about someone who'd been on the PrEP sometime in the past, but he stopped 6 months ago, but because he forgot to fill his prescription. Is it the same calculus? Would you start him on antiretroviral therapy today? What lab tests would you order pre-treatment? What therapy would you choose? In a patient like this, the question of resistance becomes more of a concern. As I've mentioned, I'm very conservative with same-day or rapid start. I like to initiate therapy with a 3-drug regimen and then think about simplification sometime later on down the line. So let's just look at some of the data that will help us to answer this question. These were studies done in New York City looking at people who had previously used PrEP. So it was 3,600 patients diagnosed with HIV in the previous 6 months. And out of that group, 2%, 91 of them had used PrEP in the past. And the average time to using it was 250 days before. PrEP users were more likely to be younger, white, and male, and men who have sex with men compared to those who had never been on it before. And this is what they found. So they didn't have genotypes in everybody, but still we're getting a pretty good sample. So we're comparing the guys who were never on PrEP to those 91 who were. And you can see striking differences. It's a little bit out of line here, but this K65R is 0 and less than 1%, thankfully. So very little K65R. And that continues to be the reports from people who've taken PrEP. On the other hand, out of these 91 who had been on PrEP before, 29% had the M184V, and fully a third had acute HIV infection. So I just want to say that in that setting, this is not a deal breaker for the efficacy of subsequent antiretroviral therapy. That is the presence of one mutation, the M184V, and I'll show you some data on that. But it certainly gives pause and is the reason that I think it's reasonable to be very conservative. The question would not be the worries about the M184V. It would be, are there other genetic mutations that we're missing with a standard genotype that might still be present and could present problems in the future? So I would still be comfortable, even in that setting, knowing someone had been on PrEP before, with a rapid start. I'd want to see what their genotype resistance test shows. But as before, I would limit their initial therapy to a fully active 3-drug regimen. And so we're back to the same question. What if he's currently on PrEP and says he's been continuously taking it as prescribed, and he has multiple partners and many who he knows are HIV infected? Well, we know PrEP is highly effective. So breakthroughs of HIV while people are on PrEP are actually remarkably uncommon. So this is the 6 that have been fairly well documented in the literature. Maybe the most widely and well characterized is this young man in Amsterdam who had a wild type virus, no resistance mutations. He was fully susceptible, and he was known to have high drug levels by dried blood spots. But the interpretation in his case was he was having 30 to 50 sex acts per day. I mean, he was extremely sexually active. In the other cases, drug resistance appears to possibly have played a role, either FTC resistance or FTC and TDF resistance. So what if the virus load was less than 200 and you couldn't do a resistance test? How would you manage the patient in that setting? Well, let's again just think about what we know about the development of resistance in people on PrEP. And I go back to the Thais who did this really, I think, very important study looking at people in the acute HIV cohort in Bangkok. Out of 2,400 people who started PrEP, there were 7 who started PrEP at a time when they were incubating HIV, when they had acute HIV. It was unknown at the time, but later they found this out. And they found that 3 out of the 7 had FTC resistance and 4 out of the 7 had no FTC resistance. And what you're seeing here is the characterization of the timing. So people who were identified who were in the first month following the PrEP, so they had only used PrEP for 2 to 15 days, only had wild type virus. So there was no resistance there. If they had been on PrEP for something longer than that, 30 days or longer, and they had started it while they had acute HIV, they'd given the virus more time, those were the people who developed the M184V or the M184I. So you can use some clinical judgment in deciding whether or not resistance is potential if you find acute HIV, just based on the time frame. And there were comparisons also to what happened in the acute HIV cohort in Bangkok for people who had not been on PrEP. And you can see there was nobody out of 229 with FTC resistance, but there was 1 patient with tenofovir resistance. So at least that gives you, I think, some reasonable clinical way to approach the problem. So I'm going to finish this second session. Let's see, we're halfway through here now, with some key points. So the rapid start of ART, which can include same-day diagnosis and treatment, but you hear me defining it in the first week or so, is likely to be of benefit. It's unlikely to lead to harm, and it certainly will reduce virus load more quickly and have a public health benefit. And in some hands, it's been associated with greater likelihood of retention in clinic and virus load suppression, but that's not uniform. And I think it's a very idiosyncratic response for you and your clinic and your institution. Do you have the resources to mobilize everything you would need not only to give the patient their medicines, but to enroll them to do good case management and potential mental health screening and obtain their labs in the same day. And in other words, what happens if the patient doesn't show for the next visit, as you hope they will, to maintain a continuous drug supply. Here in Illinois, with our enrollment in ADEP, that process actually takes a little bit of time. So you have to be sure that you can not only start a regimen, but then actually be able to sustain it. For high-risk individuals who previously received PrEP and then have become HIV infected, there's a higher risk of having antiretroviral drug resistance. Almost a third had the M184V. Now, that's not going to interfere with the choice of the next regimen, but it's a factor. Failure of PrEP when taken with a high level of adherence is very uncommon. I would say rare. I just showed you 6 cases. Those are really the best 6 documented cases in the literature at the present time. So well over 90% efficacy for PrEP when it's taken properly. And I include in that daily PrEP for men who have sex with men and for women. For women, daily PrEP is the only way they can take it. And for men who have sex with men or those who engage exclusively in rectal receptive sex, the use of the on-demand formulation for TDF and FTC, the 2+1+1 formulation, is also associated with high degrees of success. In fact, half of the PrEP that's being used currently in Paris is being used in that on-demand fashion. And then the initiation of PrEP during an episode of acute HIV infection certainly increases the risk of drug resistance. I think you all know that. I'm going to pause for a second and see if we've had any additional questions come in.
It doesn't look like it at this point, Dr. Sherer.
Okay, then I'm just going to keep going. Okay, let's think about treatment experience. What would you say about a 45-year-old black man who's been on HIV therapy for 20 years, who started on efavirenz, zidovudine, and 3-TC when he was 26 years old, at which time he was unemployed. He was intermittently using methamphetamine, and all he remembers is his virus load was high, but he did need prophylaxis for that pneumonia. So that's a useful clinical history, right? That suggests that his T cells were over 200 at that time. And he did all right with therapy initially, but soon took his medication intermittently. He lost to follow-up and back and forth. So in 2005, he had an HIV RNA of 27,000, CD4 cell count of 225, and records from an outside clinic showed him with a genotype with a K103N, M184V, M41L, and a T15. So some TAMs and K103N for efavirenz resistance. Also at that time, he was treated for depression. He entered a rehab program, and over the next year, he completed his GED. So now late 2006, he started on a regimen of raltegravir 400 BID, darunavir 600 BID, ritonavir 100 BID, and tenofovir and FTC. And his viral load rapidly suppressed, and his CD4 cell count rose to greater than 400. Not such an uncommon story when somebody gets their act in their life together and is able to adhere to antiretroviral therapy, including a rougher regimen like this, or just a more complicated one with multiple pills and BID therapy. Good control and good happens, and CD4 cells rise. So I'll continue with the case. Since that time, his ART has been modified over time, and while his T cells are over 700 and his virus load's been suppressed, so that's pretty good. We're talking about several years of good control. So he was changed to the once daily darunavir, ritonavir 800-100 formulation, with raltegravir changed to dolutegravir and darunavir to the fixed dose combination of darunavir and cobicistat. And then most recently, he was changed to the fixed dose combination of darunavir, cobicistat, TAF, and FTC, and he's still on single dose dolutegravir. So his virus load is suppressed. He works in a coffee shop. He manages the coffee shop in a college town, and he and his partner are finally married. He's immune to hepatitis B, hepatitis C, antibody negative. He has hypertension on amlodipine, but no other medical problems. And he's tired of taking pills every day. He's got a lot of them because of his blood pressure as well. So he really wants to be on the simplest therapy possible. The recent COVID pandemic has made him feel especially anxious, and he is feeling similar to that when he was first diagnosed with HIV, and he's tired of being reminded of his HIV every day. He wants to be more like his partner who is HIV negative. So he wants treatment simplification in the worst way. So what are the options? And one is just to say, you know, I understand how you feel, but I really can't help you. Why argue with success? Things are going well, and you're on a greatly simplified 2-pill once a day regimen. Could you just drop the dolutegravir and see if he did all right on the boosted darunavir based regimen? What about stopping the boosted darunavir and go with dolutegravir plus TAF FTC or bictegravir FTC and TAF, the fixed dose combination? So you're down to 1 pill once a day. Or something else. What about the new injectables that are coming down the pike?
Dr. Sherer, there was just a comment that came through.
Please.
What about low nadir CD4 having increased risk for worse COVID symptoms and death?
Yeah, well, I mentioned that is a concern. There's a discussion happening right now in the literature around eligibility for vaccination, whether all HIV patients should be on that list. Many have included it on that list. And actually there's some state-by-state variation in that. And my own feeling is we're making a mistake by spending too much time parsing out these criteria and seeing if people meet them or not. And that's just going to be a barrier that, to the greatest extent possible, while we do need to make it rational, I believe that we should get as many people vaccinated as quickly as possible. Personally, even though I showed you some data that said we didn't think that there was greater susceptibility for all patients, because people with HIV are at risk of having lower T cells or of virologic failure, also have a greater incidence of comorbidities. I do think you could make the case that HIV alone should qualify for vaccines. Within the population of everybody with HIV, certainly people with lower T cells, less than 250, should be among the first eligible. People with age over 65, those with diabetes, hypertension, chronic kidney disease, all would be reasonable to be in that group. So thanks for the question. So, you know, it's interesting, we're still actually looking at this population with this study. This was a study explicitly designed to look at changes from a current antiretroviral regimen that's stable and suppressive to a simplified regimen, in this case, the second generation integrase inhibitor bictegravir with TAF and FTC. And so you see here the design of the study where patients were randomized 2-to-1 to either switch to just 1 pill once a day or stay on whatever it was for 24 weeks and then make the switch. So, and you can see that in this fairly large study, the mean age was 49. These were all African Americans. You can see overall orientation, mean T cells like our patient was in the 700s. There were some folks who had hepatitis B co-infection, and you guys remember you're safe to use this 3-drug combination in people with hepatitis B co-infection. So what's important in these results are full equivalence, really excellent results at the 24-week time point with clear demonstration of non-inferiority. So in this setting, the bictegravir FTC TAF was equally suppressive to the original regimen. And you notice that there were no specific criteria here for previous treatment or for previous existence of resistance mutations or not. So in a nested study within that, those with pre-existing resistance, they included, I'll go to the inclusion criteria first, people who had the M184V, who had a couple of TAMs, who had other substitutions, any NNRTI resistance mutation, and any PI resistance mutation. The only ones they excluded were either 3 or more TAMs or one of the insertions, the K65R, or primary integrase resistance. So this is a fairly broadly inclusive group. And our patient, say a single M184V, would also have fit into this group. So just to categorize the resistance substitutions a little more in terms of nuke resistance, that was present in 13 to 16%, non-nuke resistance 19 to 21%, PI resistance 11 to 15%. And there was even 1 or 2 percentage points of people with integrase resistance mutations that were enrolled in the study, even against the enrollment criteria. It really didn't matter if you did or did not have protease resistance, RT resistance, or integrase resistance in this box, nuke resistance here, or the M184V alone. And you see the numbers are somewhat greater when you look at these two later categories. So again, a sense of some reassurance that a small amount of pre-existing resistance will not blunt the effect in the setting of a switch to, in this case, second generation integrase inhibitor in a 3-drug regimen. There's other data that are similar to this. This was a study looking at baseline nuke resistance and viral blips in patients when a comparison of the bictegravir, FTC, and TAF to the dolutegravir, FTC, and TAF. And you can see these different categories of resistance mutations and how many were enrolled. So it was around 280 patients in both of these groups. And they categorized people by either high, low, or no resistance. So there were a total of 565 individuals, and you can see they were pretty well distributed for those who either had 3 TAMs or more, or the K65R, those who had other nuke mutations, and then the bulk, 3/4 of patients had no resistance mutations whatsoever. And just looking at the incidence, so the point of this study was not just looking at virologic failure, but was there a greater likelihood of blips when you have pre-existing resistance? And you can see we really don't get very much of a signal. These are small, even though the numbers are somewhat small, they're very small percentages of participants who have blips in either of these categories. So I'm going to return to the question now for our patient who's on this fairly complicated regimen, although it's been simplified over time. Remember that he's now on a single pill with a boosted PI, darunavir, and dolutegravir in combination. So what are the options for him? And if we just walk past these earlier ones for no change in therapy or switching on one or the other, would it be all right to go to the dolutegravir rilpivirine, dolutegravir lamivudine, boosted darunavir, or dolutegravir? And remember that he had previous resistance mutations in 2005 that included an NNRTI mutation, K103N, for nuke mutations, and then 2 TAMs. And from what we saw before, it looks like a bictegravir 3-drug regimen with TAF and FTC would be satisfactory. A dolutegravir plus TAF and FTC would be satisfactory. What about these 2-drug regimens of dolutegravir rilpivirine or dolutegravir lamivudine, or the 2-drug regimen of boosted darunavir plus dolutegravir? So that takes us then to some of the early data looking at the combination of dolutegravir and rilpivirine, 2-drug regimen in the SWORD studies that was found to be completely non-inferior to other categories. So very excellent performance in the earlier late switch. So this is switch from whatever regimen the patient was on to either an early or a late switch to the dolutegravir rilpivirine containing regimen. And this was just the appearance of those studies over a prolonged period of time. And so that the reason that to look at that 2-drug regimen is to think then, well, what about this long-acting cabotegravir and rilpivirine? What about starting therapy in that regimen? Because we just looked at another combination with dolutegravir and rilpivirine, another potent second-generation integrase inhibitor. So let's look at some studies that may help us and inform our response to that. And I'm probably going to make this the last section because I see that I've got about 10 minutes left, and this will take me just a little bit of time to walk through. So you guys will remember that the FLAIR study was treatment-naive patients, 800 of them, out of whom 629 were started on first on an oral regimen for 20 weeks of dolutegravir/abacavir 3-TC. Those folks who were doing well on that regimen then were randomized to stay on that same oral regimen for 96 weeks or to switch to a 1-month regimen of oral cabotegravir and rilpivirine, and then finally to switch to every 1 month cabotegravir and rilpivirine. Kind of a long structure, but for obvious reasons, they wanted to make sure there was good control first, and then no unexpected adverse reactions to these two particular compounds. So what you can see is two different ways of measuring success, either virus load above 50 or virus load below 50. And clearly cabotegravir was non-inferior to dolutegravir/abacavir 3-TC over the course of that study. Confirmed virologic failures were rare. They were like 1 to 1.5%. And interestingly, as we've seen with these injectable trials, oral treatment satisfaction was substantially higher with the injectable than it was with everyday oral dolutegravir/abacavir 3-TC. One of the striking things about the preclinical and clinical trials with cabotegravir and rilpivirine has been their popularity. People enrolled in the trials really do like getting a shot, in this case, every month, and then in the next studies we'll look at every 2 months. Much prefer that to taking pills. So the Atlas was a similar design, except for they were taking people who were already on a regimen, who were well controlled, and then they randomized them 1-to-1 to get the same regimen that half the group got before, the oral cabotegravir rilpivirine regimen. And then either they went to every 8 weeks or every 4 weeks. So this is Atlas 2M. And the important part of this study is that there was no apparent difference in the ability of the every 2 monthly injections to control the virus every bit as well as the every 1 monthly injections. So, and you can see how narrow these blister plots is. So this is very reassuring that if we're going down the road of a long-acting injectable maintenance therapy, remember this is not for induction, this is only to maintain someone who's already achieved virus load suppression, we can give it to them every 2 months. In terms of the resistance data and the safety, there were very few signals. You can see confirmed virologic responses with rilpivirine mutations and with integrase mutations in the 8-week and the 4-week group. Now, I will say that there's one concern. Compared to the 3-drug studies with oral dolutegravir, or with oral bictegravir for that matter, with the second-generation integrase inhibitors, we haven't seen any resistance at all in the presence of a 3-drug regimen. When there were virologic failures in the Atlas 2M, that was not the case. So we did see in the Q8-week arm that 5 out of 8 confirmed virologic failures had rilpivirine mutations. These were pre-existing. And then 5 out of 8 had the L74I mutation. One of them had the resistance mutation for the integrase inhibitor. Now, 9 out of 10 of these patients, when they had developed a blip, resuppressed on a fully active oral agent. So that does offer us the reassurance that if there's virologic failure in clinic on these injectables, people do respond quite well then to a 3-drug fully active highly therapy. Certainly these were pretty well tolerated. Most of the injection site reactions were grade 1 or 2. They lasted an average of 3 days. So the patients who really like this prefer to have 3 days with a sore butt, because this is 2 different injections over that time, and to have that every 2 months rather than the burden of taking pills every day. And then once again, the patient satisfaction was very high. Most patients preferred this to taking a pill. But I do think that the observation of resistance mutations, both in the integrase and with rilpivirine, is a reason for continued study and looking for the phase 4 outcomes. Now, there was a lot of data that was presented recently on the feasibility of implementing long-acting, and this was, you can see, across the world. Such issues as benefits or issues in privacy and convenience, in reduced side effects, and also very separate reports from provider concerns. So these are the kinds of things that our patients were concerned with. And certainly convenience was by far and away the greatest, so that you don't have to think about taking medication, and the psychological effects. In our clinics, people are concerned with, and I am, what if somebody doesn't come back in time for their appointment? So we're shifting the burden of individual adherence daily to the burden of coming to clinic, which is actually quite a big deal, and especially in the COVID-19 era, even a bigger deal. What about the risk of resistance if people aren't adherent and they miss, even if we have a schedule where we supplement their drugs with oral drugs, which was part of the clinical protocol? That certainly is a potential risk. Or just the simple logistic issue, patient moves out of the area, there's a switch to a different provider, and that provider is not familiar with the use of the drug in this way. Drug interactions with other comorbidities, which of course is a lot of intense investigation is going on. In our setting, we've looked at the coming of long-acting therapy, the expected coming of injectable cabotegravir and rilpivirine. And I think clinicians are eager to try it. Many of our patients have expressed an interest. And I think there's also a general conservative sense of a need to put the system in place. Who orders the drug? Who stocks the drug? How do we maintain this? How do we do follow-up for patients? So I think there's quite a desire to take it slowly as we get our feet wet with the use of injectable drugs. So here's one of the reasons for those concerns. This is the pharmacology of cabotegravir and rilpivirine after long-acting HIV treatment discontinuation. And what's very important here is 12 months later, you can see that there is detectable, meaningful levels of virus in substantial numbers of frequencies in our patients. So that we have to be concerned that once we've introduced these injections to patients, they're going to have detectable drug, either with detectable side effects or potential resistance implications for 12 months after their last injection or longer. And so they have to be covered with antiretroviral therapy to diminish the chance of resistance against those drugs. And not only they have to be covered and prescribed, but they have to be adherent, in which case we're back to the problems of adherence to oral medication. So these are complicated. I think there's such an interest in the community that we do have the responsibility to take them and use them at best advantage, and to learn how to best use them in our clinic. So I want to finish with the key points, and I see a couple of questions there. Certainly for people with HIV who are already on suppressive therapy, there really is potential for simplification. A lot of good evidence base for simplification to a range of medicines. I talked about the integrases. There's also good data for simplifying to the second generation NNRTIs like rilpivirine, or the other points there are for people who are living with HIV who are suppressed on therapy, even if they've had some prior resistance. We've seen that an integrase inhibitor therapy with TAF and FTC is highly effective in the absence of primary integrase resistance. Two-drug combination with an integrase and an NNRTI like dolutegravir and rilpivirine can be highly effective as a switch. And we've seen that long-acting cabotegravir plus long-acting rilpivirine is effective at maintaining virus load suppression, was non-inferior with very infrequent breakthroughs and really acceptable toxicities, still with some confusing issues related to that point. So I'm going to stop sharing at this moment and then just look at those last questions in the chat. Well, yeah, so one of the questions is, what about the medical cost for the patients for follow-up injections? I think that patients will logically be charged for every visit that they return to in our institution. And we are talking about 6 visits a year. That's much more frequent. We believe that our insurance will cover it, and that's, credible insurance. And so I would be very careful to get an answer to that in your own issue, in your own treatment area. So it's a really important question. This is going to take more provider time. It takes an experienced professional. You can't, these injections at the moment can't be given self-administered. And so we may be taking a fairly simple, stable patient who comes to clinic twice a year rather, and now increasing it to 6 times a year with the additional volume issues in very busy clinics. So I think we're still just working this out, and I think that's an excellent question. I don't want to keep you all any longer than this 1 hour that you signed up for. I'm grateful for your attention and for being here today, and we'll look forward to the next time. So thanks for being here.
Thank you all for joining, and thank you for your time, Dr. Sherer. I will be in touch with everyone with post-program information. Thank you so much.
Thank you. Bye-bye now.